now I'm going to do a very important topic. This topic is important for the undergraduate students, for their Viva purposes and practical purposes, for all the students who are preparing for their NEET PG or Central Institutes for any clinical questions or image-based questions which can be asked, right? And this is instrumental delivery. Now, when I say instrumental delivery, what does that mean? That you are doing delivery, you are delivering the head of the fetus either by using vacuum or by using forceps, right? So what is the indication for doing instrumental delivery? See, indication for an instrumental delivery are, number one, if the second stage of labor is prolonged. So in the video on abnormal labor, I told you if the second stage of labor is prolonged and if the station of the fetal head is more than equal to +2 station, then in that case you go for instrumental delivery, right? And why did I add this condition that the station has to be more than equal to +2? That is because these days we do instrumental delivery only if the station of the fetal head is +2 or below that, right? The second indication for doing instrumental delivery is if there is fetal distress. Again, in brackets, it should be understood that you are going to do cesarean, you are going to do instrumental delivery for fetal distress only if the station of the fetal head is more than equal to +2, right? Now, suppose you get a question where they say that there is fetal distress in first stage of labor. Now, if there is fetal distress in first stage of labor, that means the cervix is not fully dilated, right? And always remember, I am going to tell you that one of the prerequisites for instrumental delivery is that the cervix should be fully dilated. Now, in first stage of labor, cervix is not fully dilated. So, you cannot do instrumental delivery in first stage of labor. So, if there is fetal distress in first stage of labor, always the management will be cesarean section. Right? Similarly, now if your question says there is fetal distress in second stage. Now, second stage means that the cervix is fully dilated. And if the cervix is fully dilated, yes, instrumental delivery can be done. But on what condition? On the condition that the station of the fetal head should be more than +2. So, if you get a question where they say that there is a female who's in labor and there is fetal distress which happens in the second stage of labor, the next thing what you should look is what is the station of the fetal head they are telling you. If they are saying that the station of fetal head is +2, +3, +4 or +5, then go for instrumental delivery. But if they are saying station of the fetal head is +1, 0, -4, -3, -2, in that case, you will have to go again for cesarean section. Understood by all of you? So, one indication for doing instrumental delivery is when the second stage is getting prolonged. Second indication for doing instrumental delivery is when there is fetal distress. But in both these conditions, the station of the fetal head should be more than equal to +2. Third indication is to cut short the second stage of labor. Right, so just now the second stage did not get prolonged, but you have to cut short the second stage of labor. This is called as the prophylactic use of forceps or vacuum. This is the prophylactic use of forceps or vacuum. And when would you want to cut down the second stage of labor? You would want to cut down the second stage of labor if the mother is exhausted. Right? So, in that case, I'm going to go for instrumental delivery. Or if there is a heart disease patient or a PIH patient. Right? So, if mother has heart disease or if mother is a case of PIH, in that case also I would want to cut short the second stage of labor and then also I will have to do instrumental delivery. Again, the principle remains the same that you will apply forceps or vacuum only if the station of the fetal head is more than +2. Right? So, you are going to wait till the station becomes more than +2 or it becomes +2 and then you are going to carry out the rest of the delivery with the help of forceps or vacuum. Clear to all of you? Okay. Then, what are the prerequisites for instrumental delivery? See, the prerequisites for instrumental delivery in terms of cervix are, number one, the cervix should be fully dilated. You are going to apply forceps or vacuum only in a fully dilated cervix. Number two, when we talk about the head of the fetus, the first thing is that the head of the baby should be engaged. Unless and until the head is engaged, you are not going to apply forceps or vacuum, and this is but obvious. I am saying we apply forceps or vacuum when the head is +2. So obviously head will be engaged, then only you are applying forceps or vacuum, because engagement means that the head is at 0 station. Right? So if it is at +2, 100% the head is engaged. Next, I have been telling you that the station of the fetal head should be more than equal to +2. Number 3, head of the baby should be rotated. Now, what do you understand by this term that the head of the baby should be rotated? That means that the sagittal suture of the baby, it should be lying in the antero-posterior diameter of the pelvis, right? So the sagittal suture, so head of the baby, it should, so suppose if this over here is pubic symphysis. So the occiput should be direct occipito-anterior position. Now, if occiput is direct occipito-anterior position, then only the sagittal suture will be in the antero-posterior diameter, or the head should be in occipito-posterior position. If the head is in occipito-posterior, direct occipito-posterior position, then also the sagittal suture will be in antero-posterior diameter, right? So the head of the baby should be either direct occipito-anterior position, or it should be direct occipito-posterior position. That is the ideal condition. Yes, some degree of rotation is acceptable. And what is that some degree of rotation? That some degree of rotation is 45 degrees. So the maximum rotation which the sagittal suture should be deflected or rotated by is 45 degrees, not more than that. Right? So I am saying this over here is the sacrum. This is pubic symphysis. Right? And over here, if this is the baby's head and this is the sagittal suture. So I am saying that the sagittal suture should be in antero-posterior diameter, right? In other words, the position should be either DOA or it should be DOP. Then only you have to apply the instruments, forceps and vacuum. The next statement which I said is that even if it is rotated, then the maximum rotation should be 45 degrees, not more than that, right? So 45 degrees on either side, not more than that. That means you can also apply instruments in LOA position and ROA position. Maximum deflection should be 45 degrees, not more than that. Ideal situation is that the sagittal suture should be in antero-posterior diameter, right? Then, so that was the prerequisites which were needed with respect to the fetal head. Now, with respect to pelvis, there shouldn't be contracted pelvis. Instrumental delivery, it cannot be conducted on a contracted pelvis. There shouldn't be any cephalopelvic disproportion. Management of cephalopelvic disproportion is always cesarean section. You never apply instruments in case of cephalopelvic disproportion. That means in your questions, you shouldn't be getting words like severe molding, grade 3 molding or caput formation. Right? So the question shouldn't, if grade 3 molding is present or if the question says that there is a caput succedaneum. In that case, that means there is cephalopelvic disproportion. In that case, do not apply forceps or vacuum. Uterus should be contracting. So when you are pulling the fetal head with the help of vacuum or forceps, you have to pull it only when the uterus contracts. When the uterus is relaxing, you are not going to pull at that time, right? So you have to pull only while the uterus is contracting. And the bladder should be empty, right? Now, when you are conducting instrumental delivery, please always, before conducting instrumental delivery, you have to take a consent and you have to give episiotomy. So, these are all prerequisites which are needed for instrumental delivery. Now, all these prerequisites, they can be, memorized with the help of a very famous mnemonic, which I have not made. This is a standard acronym which is used, FORCEP, where F stands for favorable position and favorable station. In other words, station should be more than equal to +2, and position means that it should be DOA or DOP or ROA or LOA, right? O stands for os should be fully dilated. In other words, cervix should be fully dilated. R stands for head should be rotated. Head should be rotated. Membranes should be ruptured. C stands for uterus should be contracting. Consent should be taken. E stands for head should be engaged. Episiotomy should be given. Right? So, head of the baby should be engaged and episiotomy should be given. P stands for pelvis should be adequate. P also stands for CPD should be absent. There shouldn't be any cephalo-pelvic disproportion. Yes, clear to all of you? So, all these are the prerequisites for instrumental delivery, which can be easily memorized with the help of this mnemonic, right? Then, see, in instrumental delivery, we have the two very important instruments. One is forceps, the other is vacuum. Now, all the prerequisites which I told you just now, all of them are needed for forceps delivery, right? So, forceps delivery can be conducted only when all the prerequisites which I told you, all of them are fulfilled, right? But when we talk about vacuum delivery has two exceptions. Number one exception is vacuum delivery, it can be conducted or vacuum can be applied even if the cervix is not fully dilated. In an incompletely dilated cervix, so if cervix is more than equal to 6 centimeters, you can apply vacuum, right? Number two, vacuum can also be applied on non-rotated head of the baby. So, if head of the baby is not rotated, then also you can apply vacuum. So, suppose head of the baby is at LOT position, right, or ROT position. So, the angle becomes 90 degrees. So, in 90-degree angle, you cannot apply forceps because maximum forceps can be applied if the rotation is less than 45 degrees, right? But a vacuum can be applied because vacuum can be applied even in unrotated heads. And so these are the two advantages of vacuum over forceps. Both these are the two advantages of vacuum over forceps. Clear to all of you? Now, if these two statements are clear, please remember that although vacuum can be applied when the cervix is more than 6 centimeters dilated and it can be applied in non-rotated heads, but always it is best to apply vacuum in a fully dilated cervix and with the head fully rotated. So, best results will come if you apply vacuum in a fully dilated cervix and in a rotated head, right? One thing is it can be applied, the other is best results are going to come, right? What are those conditions in which vacuum is contraindicated but forceps is used? Those conditions are, number one, in preterm babies. In preterm babies, we do not apply vacuum because when you apply vacuum, vacuum is applied on the head of the fetus and then pressure is generated, which suction pressure is there, and through that pressure we pull the baby. Now, if you apply vacuum on a preterm baby's head of the preterm baby is very, very soft. Right? So that can lead to intracranial hemorrhages. And that is why in preterm deliveries, we do not use vacuum. For the same reason, we do not use vacuum if I am conducting delivery of an intrauterine death of a baby. Now, if there is intrauterine death of the baby, the head of the baby, it becomes macerated and soft. Right, so when the head of the baby becomes macerated and soft, the pressure which I need to generate the vacuum and the plane which I need, I will not get, right? So the head is so soft that the vacuum cup will not apply and the pressure will not be generated. So if there is intrauterine death of the fetus and the head of the baby has become macerated, I cannot apply vacuum, I can apply forceps. Third condition where you cannot apply vacuum is in after coming head of breech. In after coming head of breech. So what do you understand by the term after coming head of breech? After coming head of breech means, so over here imagine this is the pelvis, right? The entire body has delivered. Head is the last part to be delivered in breech. Now, in this case, I cannot apply vacuum. Where am I going to apply vacuum? The entire body is out, but the entire head is inside, right? So, I don't have any place to apply vacuum. But on the sides, I can apply forceps. So, in case of after coming head of breech, again, I can use forceps, but I cannot apply vacuum. Similarly, in face presentation in mento-anterior position. In face presentation in mento-anterior position. So, in face presentation, you can apply forceps on the sides. If I have to apply vacuum, I will have to apply it on the face of the baby. Obviously, I am not going to apply vacuum on the face of the baby. Why am I specifying mento-anterior face presentation? That is because if you remember, I have told you in malpresentations that in face, whenever there is mento-posterior face presentation, you always have to do a cesarean section, right? So even forceps are not used in mento-posterior face presentation. But in mento-anterior face presentation, we go for a vaginal delivery, and in that case, just in case the need arises and I have to do an instrumental delivery, I will be using forceps, right? Now, so one very important thing which you have to remember is that, see, forceps can be applied in breech presentation. Forceps can be applied in face presentation also. But as far as vacuum is concerned, vacuum is used only in vertex. Right? So when the presenting part is vertex, then only you can apply vacuum. Yes, it can be used in occipito-posterior, it can be used in occipito-anterior, it can be used in occipito-transverse. Right? It can be used in any of these positions. But then the presenting part has to be vertex, then only you can apply vacuum. Right? You cannot use vacuum in breech. You cannot use vacuum in face presentation. Clear to all of you? Okay. One very common mistake which all of you think is that when we say that forceps is used in breech presentation, so whenever we are saying forceps is used in breech presentation, that automatically means that we are using forceps to deliver the head in breech. We are not using the forceps to deliver the buttocks in breech, right? So always when we say that forceps can be used in breech, that means it can be used to deliver the head of the breech. Clear? Now, there is one condition where both forceps and vacuum can be used, but forceps are preferred over vacuum, and we have read that condition. That is when the mother has heart disease. When the mother has heart disease, I told you, you have to cut short the second stage of labor, and in order to cut short the second stage of labor, you can use forceps, you can use vacuum. We prefer forceps. Why? Because when you are using forceps, the maternal efforts are less. And in a heart disease patient, we do not want the mother to make efforts, right? And that is why in a heart disease patient, forceps are preferred over vacuum, right? Now, what are the absolute contraindications for any kind of instrumental delivery, whether it is forceps, whether it is vacuum? Number one is if there is cephalopelvic disproportion. In cephalopelvic disproportion, whether it is forceps, whether it is vacuum, it is contraindicated. Similarly, if you have got an inadequate pelvis, in other words, contracted pelvis. In a contracted pelvis also, forceps and vacuum are contraindicated. Third contraindication is, suppose if I know that the baby whom I am delivering has got skeletal deformities like osteogenesis imperfecta. So in that case also, I will not use a forceps or vacuum. Or if I know that the baby whom I am delivering has got coagulopathy. So baby is a known case of coagulopathy. In that case also, the use of forceps and vacuum is contraindicated, right? So the four contraindications are cephalopelvic disproportion, contracted pelvis, if the baby is a known case of skeletal deformities like osteogenesis imperfecta, and if baby is a known case of coagulopathy. In case the mother is HIV positive, although it's not a contraindication, but we avoid using forceps and vacuum, right? So in HIV positive females, yes, you have to avoid using forceps or vacuum. Clear? Now let's talk separately about vacuum delivery. See, vacuum delivery, it is done with the help of vacuum cups which are connected to a suction machine which will generate pressure, right? Now, these cups which are available in the market earlier, when I was doing my PG, the cups which were available were metallic cups. But nowadays, the cups which are available are the Sialistic cups. These Sialistic cups, they are much more softer, and that is why they are less traumatic and they are easy to apply. That is why these days we do not use metallic cups for vacuum delivery, right? Now these cups, the shape of the cup, either it can be a bell shape or it can be mushroom shaped cups, right? And these cups, then they are attached to a suction machine. And when they are attached to a suction machine, pressure is generated. How much pressure is generated? The maximum pressure which is generated is 0.8 kg per centimeter square, right? So maximum is 0.8 kgs per centimeter square. This pressure is generated over 0.2 kg per centimeter square. So gradually you have to increase the pressure from 0.2 kg per centimeter square. So this was the initial pressure. Initial pressure which is generated is 0.2 kg per centimeter square. Maximum pressure which is generated is 0.8 kgs per centimeter square. Or you can also say that the maximum pressure which is generated is 600 millimeters of mercury, right? So initial pressure is 0.2 kg per centimeter square and maximum you have to take it up till 0.8 kgs per centimeter square or 600 millimeters of mercury, right? So initially it was said that when you have to take pressure from 0.2 to 0.8, it takes time, and that is why vacuum delivery earlier was, not preferred when there was fetal distress. But now this criteria has gone. Now the machines which we have, they generate this much pressure within 2 minutes. Within 2 minutes from 0.2 to the pressure per kg centimeter square, it goes to 0.8 per kgs, 0.8 kgs per centimeter square. And that is why these days vacuum can be used when there is fetal distress. So within 2 minutes from 0.2, the pressure will go to 0.8, right? Now comes how is the vacuum cup applied, and when are you going to say that it is correctly applied? See, where should you apply the vacuum cup? Vacuum cup should always be applied on a point which is called as flexion point, right? So you remember from the earlier videos that more is the head of the baby flexed, the smaller diameters are going to come out first, and that is why the delivery will be quick and it will be less traumatic. If the head of the baby is extended, it is the larger diameters which will have to traverse the pelvis, and that is why the progress of the delivery will be slow and it will be a little more traumatic also for the fetus, right? So when you are applying vacuum at the flexion point, head of the baby becomes well flexed. That is why we say that the vacuum has to be applied on flexion point. Now, when you are applying the vacuum cup on the flexion point, the center of the cup has to lie on the flexion point. That's one thing which you have to remember. So it's the center of the cup which should come on the flexion point. And where is this flexion point? This flexion point is a point on the sagittal suture of the fetal head such that it is 3 centimeters anterior to the posterior fontanelle and 6 centimeters posterior to the anterior fontanelle. I am repeating. This flexion point is a point which is there on the sagittal suture of the fetal head in such a manner that it is 3 centimeters anterior to the triangular fontanelle, that is 3 centimeters anterior to the posterior fontanelle and 6 centimeters posterior to the anterior fontanelle, right? Have you understood? So the cup or the center of the cup should fall on this flexion point. Till here, have I made myself clear? Now, the next thing which you have to understand is that the cup which we commonly use, it has a diameter of 6 centimeters. Right? Now, I want you to make a circle on this point. Right? So, I want all of you to make a cup of 6 centimeters such that the center of the cup falls on the flexion point. So on your diagram which you are drawing, please make a cup of 6 centimeters such that the diameter of the cup is 6 centimeters. So the radius of the cup will be 3 centimeters, right? Such that the center of the cup is on the flexion point. Now when you have made this cup, do you realize that the rim of the cup is exactly on the posterior fontanelle, right? So this is how you come to know that the cup is applied at the correct place. You have to apply the cup closer to the occiput in such a manner that the rim of the cup, it is falling or it is lying on the posterior fontanelle. The edge of the cup, it should touch the posterior fontanelle. If you are applying the cup in such a manner that the edge of the cup is touching the posterior fontanelle, that means you have applied the center of the cup on the flexion point. Is that clear to all of you? And obviously, you will have to see to it that the cup is correctly placed and the center is lying on the sagittal suture as well, right? Now, what if the cup is placed a little more anteriorly. See, when the cup is placed on the flexion point, as I told you, if the cup will be on the flexion point, it will maintain the head of the baby in flexion. Now, if the cup is placed anteriorly, it is not on the flexion point. In that case, when you are going to pull the head of the baby, right, when you are going to pull the vacuum cup, it will lead to extension of the fetal head. It will not lead to flexion, right? And when it will lead to extension of the fetal head, longer diameters are going to come into play and it can become traumatic. So now, if your question asks you, and this is a question which was asked in PGI, they had given all of the following statements are true, and then you had to, understand this statement. So, if they say that what is the distance between center of the cup and the anterior fontanelle? So, tell me, what is the distance between the center of the cup and the anterior fontanelle? The distance is, as you can see from this image, the distance is 6 centimeters, right? But now, if the question says, what is the distance between the rim of the cup or the edge of the cup and anterior fontanelle? So, what is the distance between the edge of the cup and anterior fontanelle? It will be 3 centimeters. Why? Because the radius of the cup is 3 centimeters, right? So, the distance between the edge of the cup or the rim of the cup from the anterior fontanelle is not 6 centimeters. It is the distance between the center of the cup and anterior fontanelle, that is 6 centimeters. So please be very, very careful when you are doing your MCQs, right? Now, these days, we also have a new device which is called as an Omni cup. Now, this Omni cup, they can give you an image-based question. So, first thing what you see over here is, this Omni cup is a vacuum. This is a vacuum device which is so small, it is portable, and you don't have to connect it to any suction machine or to generate pressure. This has got an inbuilt pump to create vacuum. So only this small little device is needed, and that is why this small little device is the entire vacuum thing. No other machine needed, nothing else needed. This is the smallest vacuum cup which we have just now. It has got inbuilt, the pump to generate vacuum. This is one-time use. You are not going to use it multiple times. It's one-time use and then you have to throw it, right? So it is disposable. It can be used both for occipito-anterior and for occipito-posterior position. So this is Omni cup. That's a new kind of vacuum device which we have now, right? Now, let's talk about forceps. Now, when we talk about forceps, the first thing what you have to know is the parts of the forceps. So, what are the parts of the forceps? Parts of the forceps are, number one is the blade, right? So, we have the blade, then you have the shank, and you have the handle, right? So, this over here is the handle from where you are going to hold. This is the blade of the forceps, and the part which is lying between the blade and the handle, this part is called as the shank. Now, as you can see, this shank is giving only length to the forceps. So, it is the length of the shank which varies in case whether the forceps is small, then the shank will be less in length, and when the forceps will be long, then the shank will be more in length, right? Now, if you look at the blade, this tip of the blade is called as the toe. Right? So, the tip of the blade is called as toe, and the base of the blade, this part of the blade, this is called as the heel. Right? So, the parts are blade. In blade, the tip is called as toe. The base of the blade is called as heel. Then you have the shank, and then you have the handle. right? Here you can see there is a lock. I will show you the lock again when we'll be talking about the types of lock, right? Now, in the forceps, there are two curves. One is a cephalic curve and the other is a pelvic curve. Now, cephalic curve is that curve which is lying on the inside. Right? So this is the cephalic curve of the forceps. This is the one which is going to accommodate the fetal head. Right? So this is the part which will be around the fetal head, and that is why it is called as cephalic curve. The inside curve. Can you see this inside curve? Okay. Then there is a curve which is called as pelvic curve. Now, most of you make a mistake while telling which one is the pelvic curve. Bachcho, please remember this edge of the blade. The edge of the blade, this is the pelvic curve. You are not going to say this is the pelvic curve. The edge of the blade is the pelvic curve. The inside one is the cephalic curve and the edge of the blade is the pelvic curve. Is that clear to all of you? Right? Now, I am going to tell you just one more thing. See, pelvic curve, you are holding the forceps correctly if the pelvic curve is facing upwards. Just now, the pelvic curve is facing upwards. That means I am holding this forceps correctly. Suppose if I hold the forceps like this. Now, if I hold this forceps like this, the pelvic curve is coming down, right? If the pelvic curve comes down, that means you are not holding it correctly. So again, look here. When you hold the forceps correctly, the pelvic curve will always face upwards. So can you see the curve going upwards? And over here, the curve coming downwards, right? So let me show you in another forceps also. So look over here. Just now, I don't know whether I'm holding it correctly or not. I just have to look at the pelvic curve and decide. Now, over here, the pelvic curve is going downwards. So because the pelvic curve is going downwards, that means I'm not holding it correctly. I should rotate it. And now if you see, now the pelvic curve is going upwards. Can you see it's going upwards? This means this is how I have to hold this forceps. Right? So this is how I am going to hold. So now I know this is the correct way of holding this forceps. This is the correct way of holding this forceps. Both the pelvic curves are facing upwards. If I do it like this, see, if I do it like this, the pelvic curve is going downwards. That is incorrect. You have to hold it like this so that the pelvic curve goes upward. I hope I have made my point clear to all of you. Okay. Now I'm also going to tell you how to recognize which blade is left and which blade is right. But just now, first, have you understood the parts of the forceps? So I'm repeating, in parts of the forceps, you have the blade, right? So this over here is the blade, right? In blade, the tip of the blade is the toe. The base of the blade is the heel. Then you have the shank and you have the handle, right? As you can see, the blade is fenestrated, right? It is not a solid blade. Why is the blade fenestrated? The blade is fenestrated because fenestration is going to make this forceps light. It will make it less traumatic because now the blade is not going to compress the head of the baby tightly. Because of this fenestration, the blade won't be very tight on the baby's head. And because the baby's head will not get compressed too much, so the trauma will be less. If it would have been a solid blade, then the compression on the baby's head would have been much more, and that would have led to more trauma, right? Then we have two curves. The inside curve of the forceps, that is called as cephalic curve, and the edge is called as, the outside edges are called as the pelvic curve, right? So the outside edge. And the rule which I told you was that always the pelvic curve should face upwards. It shouldn't face downwards, right? So over here the curve is going down. So this means this is incorrectly held. Here the curve is going up. That means it is correctly held. Clear to all of you till here? Now, there is another very important part of the forceps, and that is the lock, right? The lock. Now, in forceps, there are two kinds of locks. Number one is an English lock. Number two, there can be a sliding lock. English lock has got two sockets. On each forceps, you will get a socket. So over here in the forceps which I have, can you see a socket over here? This socket. Can you see this socket? Right? So this blade has a socket and this blade also has a socket. Right? So both the blades have got a socket each. One socket is present here and one socket is present here. So if two sockets are present, that means that it is English lock, right? And English locks are designed in such a manner that they will be closed only when the left forceps goes inside first. Only when the left blade is introduced first, then only you will be able to close the English lock. In case of sliding lock, you will get a single socket. There won't be two sockets. So each blade will not have a socket, right? There will be a single socket and the lock will be sliding. Most of the forceps have got English lock. There is only one forceps, and I'll tell you which forceps, which has got a sliding lock, right? Now, with this background, I'm going to tell you how to identify the left and the right forceps. The first thing what you have to understand is the term left and the right we use with respect to the mother, right? So the forceps which is applied on the left side of the mother, that becomes the left forceps, and the one which is applied on the right side, that is called as the right forceps. Now, how you are going to identify them? See, the first thing which you have to see is that first and foremost, you have to identify how is the forceps correctly placed. The forceps is correctly placed if the pelvic curve goes upward. Then only is the forceps correctly placed, right? So over here in this, if I say this is the correct placement of the forceps, is the pelvic curve going up? Yes, the pelvic curve is going up. So this means that for this forceps, this is how the pelvic curve is going upwards. That means it is correctly placed. It is correctly held just now, right? In this forceps, if I hold it like this, now the curve is going downwards, right? Can you see the curve going downwards? Right? So that means it is not correctly held. I will have to rotate it and I will have to hold it like this. Right? Now when I'm holding it, the curve is going upwards. The pelvic curve is going upwards. That means this is how this forceps should be correctly held. Right? Now, this is how this is correctly held and this is how this is correctly held. Now you can see when these forceps are correctly held, in one of them the socket is coming up, right? The socket is coming up, and in the other the socket is coming down, right? So in one of them, in correctly held position, the socket is coming up, the lock's socket is up, and in the other one, the lock's socket is down, right? Now, how to identify which is the left and which is the right? In the left forceps, Left forceps will be that forceps in which when you are correctly holding the forceps, the socket is coming upwards, right? So the socket is coming up. That means this is the left blade. And over here, the socket is coming down. So that means this is the right blade. Right? Now, when I say this is the left forceps and this is the right forceps, this means this forceps will go on mother's left hand side and this forceps will go on mother's right hand side. Is this much clear to all of you? First, how to identify the forceps? In correctly held manner. In the left forceps, the socket will be upwards, and in the right forceps, the socket will be downwards. Right? Now, the left forceps should be held in your left hand, right? And the right forceps should be held in your right hand, right? Now, first you are going to introduce the left blade. Why? Because in English locks, the lock is closed only if the left blade is applied first. So I am going with my left hand, I am going to introduce the forceps. Right now, when you are introducing the forceps, with your other hand, you have to guide it and you have to introduce it on mother's left side on the baby's head. Right? Now, what I am going to do? I am going to hold the right forceps in my right hand, and again I am going to gradually introduce the right forceps, and you can see that the forceps get easily closed. So if the lock is getting easily closed, that means you have applied the forceps correctly, right? So left blade is introduced first, right? So you have to hold it in a pen-like manner and you have to introduce the left blade first, right? Then hold it. Then you have to introduce, you tell your assistant to hold it. Then you introduce the right blade and you can see so easily the forceps blade gets closed, right? So that means you have correctly applied the forceps. The lock gets closed easily, right? Now I want all of you to look at this image and tell me whether this is the left side blade or whether this is the right side blade. So first thing what you have to do is you have to see whether the curve is going upwards or downwards. So draw a line across the pelvic curve. So where it is going upwards. That means this blade was correctly held. Now this blade is correctly placed. Now see where is the socket? Socket is up. Now if the socket is up, that means it is left side forceps, right? And left side forceps means it will be applied on the left side of the mother, right? Now, how to know that the forceps are correctly applied? One of the method was what I told you, that if the forceps are correctly applied, then only the lock is going to get closed. The second thing which you have to see is that if you have applied the forceps correctly, the blades of the forceps will be equidistant from the sagittal suture of the fetal head. Only if the blades are equidistant from the sagittal suture of the fetal head, that means the forceps is correctly applied, right? Now I'm going to show you various pictures of various types of forceps and I'm going to tell you in image-based questions how you are going to identify them. Right? So number one forceps which you can see on your screen is a very short forceps. Now the short forceps which will be asked in your exam is a Wrigley's forceps. In this forceps, the total length of the forceps is 27.5 centimeters, and I told you that in short forceps, which part of the forceps will be short? It will be the shank which will be the short part. So over here, the shank is very small, and this small shank is 2.5 centimeters. right? Now, Wrigley's forceps is a short and light forceps, and it is used as an outlet forceps. Just now I'll tell you what is meant by outlet forceps also, but remember that Wrigley's forceps is a short forceps which is used as an outlet forceps, right? Now what you are seeing on your screen is a very long forceps, right? And one very important thing what you are seeing here is that it has got only a single socket. Can you see? A single socket is present. That means it has got sliding lock. The only forceps which you have to know which has got a sliding lock is Kieland's forceps, right? So how do you identify Kieland forceps? A Kieland forceps is a long forceps and it has got a sliding lock. Please remember that I told you that forceps cannot rotate the head of the fetus. There is only one forceps which can rotate the head of the fetus, and that is a Kieland's forceps. That is why Kieland forceps is a rotational forceps, but this is outdated these days. We do not use Kieland forceps anymore, right? But yes, it is a rotational forceps. It can rotate the head of the fetus, right? Now, on the screen, now what you are seeing again is a very, very long forceps. Now, how are you going to differentiate this forceps from Kieland forceps? I told you, the only long forceps which has got sliding lock is Kieland forceps. In this case, sliding lock is not present. In this case, English lock is present, right? In sliding lock, you will get just a single socket. Although over here, both the sockets are not seen, but in sliding lock, always the single socket will be seen. So because here, both the sockets are not seen and not, even though both the sockets are not being seen, but a single socket is also not seen. So I know it's not sliding lock. It has to be an English lock, right? So if you are getting a long forceps with English lock, then it is Piper's forceps. Piper's forceps. And where did you use Piper's forceps? Piper's forceps was used for delivering the after-coming head of breech, right? It is the longest forceps which we have, Piper's forceps, right? The only forceps which has got a solid blade. Can you see a solid blade? There is no fenestration here, right? Is a Tucker-McLean forceps, right? Now, forceps application. See, forceps application means at which station you are applying the forceps. So, if you are applying forceps at more than +2 station, when the head of the fetus is at +2 or station or below that, it is called as low forceps application. But if you are applying forceps when the head is at the level of perineum, then it is called as outlet forceps application. Low forceps application means head is at the level of +2 station or below that, but just now head has not reached the level of the perineum. If head reaches the level of perineum and now you are applying forceps, that is called as outlet forceps. The criteria for outlet forceps is how am I going to know that I have to apply low forceps or outlet forceps? See, if the scalp of the baby is visible at the introitus and then you are applying forceps, that means you have to apply outlet forceps, right? Or if the head is at the perineum, then you have to apply outlet forceps, or if the skull is on the pelvic floor. So the criteria for applying outlet forceps is if the scalp is visible at the introitus, head is at the level of perineum, skull is at the level of pelvic floor, then you apply outlet forceps, right? Ideally, for applying outlet forceps, the sagittal suture should be in AP diameter. And there is only one forceps which is used as an outlet forceps, whose picture I showed you, and that is Wrigley's forceps. Right? So, rest all the forceps which we have, Simpson forceps, then we have the Das forceps, all these are varieties of low forceps. Wrigley's forceps is the only forceps which is a variety of outlet forceps. Right? So, these are the only two kind of forceps applications which are done these days. Either you apply a low forceps or you apply outlet forceps. In earlier days, there was something which was called as mid-cavity forceps application and high forceps application. Mid-cavity forceps application means that you were applying forceps when the head of the baby was at 0 station or +1 station, and high forceps meant when the head of the baby was above the level of ischial spine, and then you were applying forceps. But as I told you, none of these is done now. We now do instrumental delivery only if the head of the baby is at +2 station or below it. And if it is at +2 station or below it and just now the head has not reached the level of perineum and you are applying forceps, that is low forceps application. If head is at the level of perineum and you are applying forceps, that is outlet forceps application. This is a very, very important AIIMS question, right? How are you going to tell me that what is the direction of pull when you are applying forceps, low forceps, and what is the direction of pull when you are going to apply outlet forceps? Now, whether you are a final year student or whether you are a PG aspirant, I know most of you are going to do mistake when you are going to tell me the answer to this question. So, in order to make you understand, first I'm going to tell you that how to, identify what is backward, what is upward, what is forward, what is downward. Now, when we are using these terms that I am going to pull the forceps downward or backward or forward, this downward, backward and forward are based on mother's abdomen. Right? They are not based on your direction. They are based on the direction from the mother's abdomen. Right? Now, for forceps application, what should be the ideal position of the patient? The ideal position of the patient should be lithotomy position, which you can see on the screens. Right? Now, in lithotomy position and with this being the abdomen of the patient, tell me, if I am, what is this direction which is the arrow is pointing to? The arrow number 1. This arrow number 1 is pointing to which direction with respect to mother's abdomen? So, the pointer number 1 is pointing to forward direction. Arrow number 1 is forward direction with respect to mother's abdomen. Similarly, arrow number 2 is backwards. It is towards mother's back. Right? Obviously, you can see it is towards the mother's back. So, it is backward. Right? Now, arrow number 4. Right? So, the black arrow which I have made there and I have written as 4. It is facing towards the mother's face. So, it is upward. And arrow number 3 is downward. Right? So, if arrow number 4 is upward, arrow number 3 is downward. Right? And this is the mistake what you do. You call arrow number 2 as downward. Arrow number 2 is not downward with respect to mother's abdomen. It is backwards. Right? Arrow number 3 is downwards. Arrow number 4 is upwards. Right? Now tell me what will be arrow number 5's direction. What are you going to call it as? So, arrow number 5 is downward plus forward. Right? Don't say it is downward plus upward. It is downward plus forward. And arrow number 6 is downward plus backward. Right? So these are the positions, and all these positions are with respect to the mother's abdomen. Right? Now with this background, I am going to tell you how to, tell me that what will be the pull of the forceps be in low forceps application and in outlet forceps application. Now, in low forceps application, first you are going to pull downward and backward till the time the head of the baby reaches the mother's perineum. Once the head of the baby is visible at the perineum, then you are going to pull it downward in this direction. So initially it was downwards and backwards. Once the head of the baby is visible at the perineum, then it will be in this direction, and this direction was called as downwards. Once the head is, once you are brought the head, cut. I'll say it again. From here I'll come again. So when you are applying low forceps, the initial pull has to be in number 1 direction, and this number 1 direction is downward and backward. So first you are going to pull the head of the baby downward and backward. Then you are going to pull it downwards. Right? So then it has to be downwards. And once the head of the baby is visible to you, now you take it downward and forward. Right? So the first pull is downward and backward. Then it is downward, and then it is downward and forward. Right? Now, in case of outlet forceps, the head of the baby is already at the perineum. So you don't have to go for downward and backward. Simply you have to go for downward and then downward and forward. Right? Clear to all of you? Please do not say that this movement is upward and forward. This is downward and forward, and I told you why it is downward and forward. Right? So first it will be downward and then downward and forward. Clear to all of you? Okay. Again, I'm telling you that before you apply forceps, do not forget to take consent. Do not forget to give episiotomy to the patient, and please, instrumental delivery, especially forceps delivery, is a painful delivery. The perineum of the baby, the perineum of the mother gets stretched. So you will have to give adequate pain relief to the mother. This adequate pain relief to the mother can be in the form of epidural block, or it can be in the form of pudendal nerve block, because the nerve supply to the perineum is by pudendal nerve. Right? Now, I told you the direction in which you have to give the pull, right, in case of low forceps and in case of outlet forceps. Now come how much force you are going to use while you are pulling the forceps. In case of primary gravida patients, the force which you are going to use will be 16 to 18 kgs maximum, and in multigravida females, it will be 12 to 13 kgs maximum. The next very important single liner question is that in a correctly applied forceps, where in along which diameter of the fetal head are the forceps applied? So in a correctly applied forceps, the diameter along which the forceps will be applied will be occipitomental diameter. Right? Now, when we compare the complications of forceps and vacuum, it is seen that forceps lead to more of maternal injury, and forceps lead to more of maternal injury, and vacuum leads to more of fetal injury. But there are certain complications, there are certain fetal complications which are specific to forceps, and these fetal complications are seventh nerve injury, that is the facial nerve palsy, brachial plexus injury, and corneal injury. So although the fetal injuries are more common with vacuum, Maternal injuries are more common with forceps, but still there are certain fetal injuries which are more common with forceps, and these are seventh nerve injury, brachial plexus injury, and corneal injury, right? Now, if they ask you what are the, fetal complications which are more common or specific to vacuum, so the fetal complications which are more specific to vacuum, they are the sixth nerve palsy, shoulder dystocias, cephalhematomas, subgaleal hemorrhages, and retinal injury, right? So please read it as fetal, do not read it as fatal. Now, how do you define a failed forceps or a failed vacuum delivery? Failed forceps or a failed vacuum delivery means that you have tried thrice, right? You have tried thrice and still the head of the baby is not getting delivered. That means it's a case of failed forceps or a case of failed vacuum. Now, what is the management of failed forceps or failed vacuum? Management of failed forceps or failed vacuum is cesarean section. Please do not say that first I'm going to try forceps for 3 times. If it fails, I'm going to try vacuum for 3 times. No. You have to try any one instrument and you have to try it maximum for 3 times. In clinical practice, most of the times you will be seeing vacuum being used because vacuum is more easier to use. Forceps, they need special training, right? So everyone cannot use a forceps, and that is why in clinical practice you will see forceps being used less in comparison to vacuum. Right? So that is all what I wanted to tell you about forceps and about vacuum. Let's do a few MCQs and see, how to apply the knowledge which I have given you. So question number 1. A primigravida has been in second stage of labor for 2 hours, right? So primigravida in second stage of labor for 2 hours. What does that mean? That means it's a case of prolonged second stage. Remember the definition for prolonged second stage? If a primigravida female, the second stage is more than equal to 2 hours, that is prolonged second stage, right? Head is fully engaged, vertex position, and head is at the perineum. Cervix is fully dilated, membranes are absent, sagittal suture is in transverse diameter. Okay, she is getting good uterine contractions, but her bearing down efforts are poor. Fetal heart rate is dropping to 90 beats per minute. So in this case, I am getting a prolonged second stage. Patient is moving towards the second stage arrest also. And the fetal heart rate is dropping down to 90 beats per minute, right? So that means there is fetal distress. So tell me, what am I going to do? Now, if there is fetal distress and the cervix is fully dilated, so the cervix is fully dilated and the head is at the level of perineum, that means the criteria for instrumental delivery is fulfilled, right? Now, the problem here is that the sagittal suture is in transverse direction. That means head of the baby is not rotated, right? Now, if head of the baby is not rotated, what would you want to do? Whether you would want to apply forceps, whether you would like to apply vacuum, or whether you would like to go for cesarean section. See, forceps cannot be applied because forceps cannot be applied on the, unrotated head. Right? So you cannot apply forceps on unrotated head. Now I am left with the option of vacuum and cesarean. Vacuum can be applied on an unrotated head. Now because the head is at the level of the perineum, which one will be more quicker, to apply vacuum or to call the anesthetist, to give anesthesia to the patient and then do a cesarean section? As it is, this patient is having fetal distress. So time has to be kept in mind. Time is going to play a very, very important role. So here in this question, I am going to prefer vacuum delivery because it is going to happen in a lesser time in comparison to cesarean section because baby is having fetal distress. I am not thinking about the prolonged second stage of labor. Here I am thinking about fetal distress, and if there is fetal distress, I have to act very quickly. And with vacuum, I can deliver the head of the baby within minutes. Right? A primigravida has been in second stage of labor for 2 hours. Head is fully engaged in vertex presentation and is at +2 station. Cervix is fully dilated. Membranes are absent. Sagittal suture is in antero-posterior diameter. She is getting good uterine contractions, but her bearing down efforts are poor. Fetal heart rate is dropping to 90 beats per minute. So that means again there is fetal distress. What is done next? Option A, counsel for instrumental delivery. Option B, counsel for cesarean. Option C, allow bearing down. Option D, oxytocin augmentation. Now, if there is fetal distress, am I going to allow bearing down for 1 more hour? No. Am I going to give oxytocin for second stage? Here the problem is that there is fetal distress. Right? Now, in fetal distress with good uterine contractions, am I going to give oxytocin? No. Right? I have to act quickly and I have to deliver the baby. So what am I going to do? I'm going to go for instrumental delivery because the head is at +2 station. Right? And the cervix is fully dilated. So I told you when there is fetal distress in the second stage of labor and the station of the fetal head is more than +2, you have to go for the forceps or vacuum delivery. Right? If the head would have been above +2 station, then I would have gone for cesarean section. So if in the same question they would have written head is at +1 station, now my answer would have been cesarean section. Next question, vacuum is not applied in persistent occipito-posterior position. So tell me, can you apply vacuum in occipito-posterior position? Yes, you can apply vacuum in occipito-anterior, in occipito-posterior and in occipito-transverse. In any position of the vertex, you can apply vacuum because vacuum can rotate the head of the baby. You cannot apply vacuum in aftercoming head of breech and you cannot apply it on face. But in vertex, you can apply it on any position. Right? In maternal heart disease, yes. In maternal exhaustion, yes. In preterm fetus, no. Right? Forceps should not be used in. Option A, twins. So did I tell you that one of the contraindication for using forceps is twins? No. So you can use forceps in twin delivery. For aftercoming head of breech, can you use forceps? Yes, you can use. In post-maturity, can you use forceps? Yes, you can use. In hydrocephalus, can you use forceps? Now, hydrocephalus means that there can be cephalopelvic disproportion. And whenever there is cephalopelvic disproportion, you do not use neither forceps nor vacuum. Right? So, here the answer will be hydrocephalus. Right? So that brings us to the end of the discussion. Please watch the video again in order to know how to identify the blades, how to identify which forceps is of left side and which is of right side. That's a very important potential MCQ, image-based MCQ, right? And undergraduate students, you will be given forceps in your hands and you will be asked that which one is the left blade and which one is the right blade, right? Keep revising. Take care.